Good evening, everyone, and welcome to The Power of Pink, a virtual discussion hosted by Tallahassee Memorial HealthCare. I am Alicia Turner, and I am elated to be your moderator for this evening. I work for the Tallahassee Police Department as the Director of Communications and Marketing, and breast cancer is something that's very close and near and dear to my heart as it's impacted a number of women in my family. And so I'm just honored to serve as your moderator today. And I think that we have some amazing panelists that have a lot of information, a wealth of knowledge to share with you all. So thank you, each of you, to our panelists and everyone who's joining us this evening. We are joined today by an incredible panel of leaders here at TMH. Each of these individuals brings a unique perspective when it comes to breast cancer and breast care for their medical careers. What drove them to this humbling work and their prospective areas of breast cancer health expertise. Our panelists today includes Dr. Shelby Blank, Director of the Walker Breast Program and Surgeon General at TMH, Jeannine Silberman, Medical Oncologist and Hematologist at TMH, Dr. Alfredo Paredes, Plastic Surgeon at Tallahassee Plastic Surgery Clinic and TMH, Dr. Mary Swain, Radiologist at Radiology Associates of Tallahassee and TMH, Amy Anderson, RN, Breast Cancer Nurse Navigator at TMH, and Katie Farmer, MS, CGC, Genetic Counselor at TMH. Many of you submitted questions ahead of time, which I'll be sharing with the panelists during this talk. And if you have any additional questions as we go, please use the Q&A feature in Zoom to submit them. We'll be monitoring them as they come through, and our experts will answer them in real time. I think it's time that we just jump right in. We want to make sure that we give all of our panelists an opportunity to introduce themselves and share a little bit about what they do at TMH and in their respective roles. So we want to start with Dr. Blank. And can you please tell us a little bit about yourself and your work with patients who have breast cancer?
Absolutely. Thank you so much. I am a general surgeon, but a significant amount of my practice focuses on breast health and treating breast cancer. So I am usually, after the radiologist, one of the first physicians to meet with the patient, talk about the diagnosis, and then offer surgical options. I'm a general surgeon at TMH and also the medical director of the Walker Breast Center, which we have expanded over the last couple of years to offer really a full comprehensive breast experience for our new patients. So great to be here, and thanks for having us.
Thanks so much, Dr. Blank. Now, Dr. Silberman, will you please tell us a little bit about yourself and your role in patients' breast cancer journeys?
Yes, thank you. I'd be happy to. So as you said, I'm a medical oncologist. So I'm the one that gives the anti-estrogen medications for those that have estrogen receptor positive or hormone receptor positive breast cancers. I give chemotherapy. Those are really my roles. I mean, it's a little more involved in that, but those are my two primary therapies that I use to complement the work of the surgeons and radiation oncologists. Most of my practice, I'd say maybe 95% is focused on breast cancer care. So I'm very happy to be here.
Thanks so much. Now, Amy, let's switch gears. You now serve as the nurse navigator for breast cancer patients at TMH. Tell us a little bit about that.
So as the breast cancer navigator, I have a unique role to work with both men and women who are diagnosed with breast cancer. I serve as a direct point of contact to help guide them through the continuum of care, from their diagnosis through their treatment and then survivorship.
All right, thank you so much. Now, Dr. Swain, will you please tell us a little bit about your work with patients with breast cancer?
Absolutely. So I've been with Radiology Associates at Tallahassee and TMH for the past 32 and a half years, believe it or not. As a radiologist, I interpret both the mammograms and breast ultrasounds and breast MRI. And we radiologists also do many of the needle biopsies of the breast. So we're really kind of often the entry point for women who are being diagnosed with breast cancer. And I'm thrilled to be part of the TMH breast clinic that we've established at TMH.
Thank you so much, Dr. Swain. Now, Dr. Paredes, tell us about your role and the role that you play in patients' breast cancer journeys.
Sure. Hello, everybody. So my role comes in when a general surgeon will ask me to get involved with the surgical planning of a breast cancer case. That can be for a few different reasons. Sometimes it's a larger breast or a larger tumor, planning how we're going to get the skin closed. And then the second part would be for patients who are interested would be reconstruction for either after mastectomy when the whole breast is removed or after lumpectomy. And let's say there may be a partial defect, we can also help in reconstructing the mound to look more normal.
All right. And Katie, last but certainly not least, tell us about your role that you play in patients' cancer journey as a genetic counselor.
Sure. So I am the genetic counselor at TMH, and we know that about 10 to 15% of breast cancers have an underlying hereditary cause to them. And so for patients that are newly diagnosed or even been diagnosed in the past, but have concern for hereditary syndrome, I see those patients, evaluate their family histories, and talk about their genetic testing options, because if we identify there is an underlying cause to it, that can have an impact on their medical therapy choices, surgical choices, and then of course, information for their family members as well.
Fantastic. Thank you so much to all of our panelists for introducing yourselves and telling us about your work. As promised, to all of our viewers, a wealth of knowledge here amongst our panelists. And so we want to dive right in. The fact that we're on a Zoom call in 2021 is just evidence of the type of year that we've had, or almost 2 years at this point. And so we know that many people have delayed their routine checkups and healthcare over the course of the pandemic. So are you seeing that when it comes to mammograms and breast care as well? Dr. Blank, I'll let you take this as far as what trends that you're seeing among those diagnosed with breast cancer.
Definitely, the last couple of years have been a real different paradigm in terms of screening and kind of what we feel like are essential measures. I think that we are seeing a few patients that are probably diagnosed at a little bit later stage, just because their normal course of screening was a little bit interrupted. We really didn't stop doing screening for that long, but sometimes when people get out of the sync or off schedule, it's hard to remember to sort of pick that back up. So I do think we are seeing, whether that's directly related to COVID interruptions or not, but we are seeing kind of a few more patients with either positive lymph nodes or a little bit more advanced disease. And we're also seeing people who normally for the past, 10, 15 years have gotten, just like clockwork, a yearly mammogram, but now maybe it's been 2.5 years since they've gotten their mammogram, and there's something new to be found there. So definitely COVID has had an impact. And so I would caution everyone to, maybe look back at your calendar and try to, the last 2 years have a little bit been lost, and realize kind of when the last time you had a screening was, and if you might be overdue.
And on that note, as far as mammograms, Dr. Swain, talk a little bit about why they're so important, especially annually, and who should be getting them.
So screening mammograms are extremely important. Many of the breast cancers are actually diagnosed through a screening mammogram. And we recommend that all women start having their screening mammograms when they turn 40. And we recommend that you have a mammogram every year after you turn 40. And as Dr. Blank said, unfortunately, a lot of people, first of all, we had to quit screening for a while, but Dr. Blank is absolutely right that I think a lot of people got off their routine of getting their annual mammogram. And we really want to encourage everyone to start up their screening mammogram every year again.
All right. And Dr. Silberman, I'd love to talk a little bit more about early detection and screenings. What are some of the signs and symptoms women and men should keep an eye out for?
Thank you. So it's the presentation in men and women is very similar clinically. Oftentimes they'll feel a nodule in the breast tissue or under the arm. Unfortunately, men don't have routine screening mammograms because it's not prevalent enough, and so the screenings are not particularly helpful. But certainly there are some men who are at risk by virtue of, many of them by virtue of a genetic mutation. So it's important to understand, your family history, because if you are one of those men who is BRCA2 positive, you are going to want to have annual screening mammograms. So the presentation's very similar. I'd say probably half of my patients come in with a new diagnosis based on an abnormal breast imaging, and the other half perhaps feels a palpable nodule either under the arm or in the breast itself, at least for early stage detection.
I think this is something that a lot of people are constantly wondering. Are there factors that can put someone at a higher risk for breast cancer? Dr. Silberman, I think you talked briefly about that, but Katie, can you talk about genetic mutations and genetic testing?
Sure. As I said earlier, we know that about 10 to 15% of breast cancers have an underlying hereditary cause. What that means is that someone was born with a mutation, a change in their DNA in a particular gene that then places them at higher risk for breast and other cancers over their lifetime. Not a guarantee that it will happen, but a higher chance than average. And so we know that up to maybe about 40% of the hereditary breast cancers are due to those two genes, BRCA1 and BRCA2, which a lot of people in the general population have heard about at this point. But there are a dozen other genes that we know contribute to breast risk as well. And so we now have testing available that can look at all the known causes to try to identify which individuals in the population, women and men, may be at increased risk for cancer. So then we can offer them better screening, more frequent screening, earlier screening to try to change outcomes.
And this next question is really for anyone. Are there risk factors unrelated to genetics?
I'll take that. I guess we certainly know that there are, certain risk factors, one of the primary ones being age. As we get older, our risk for most cancers, breast cancer included, increases. There are other certain, not having children, not breastfeeding, having a sedentary lifestyle, carrying more weight. There are certain things that we're still kind of figuring out how strong some of these risk factors are, but those are a few, and Dr. Silberman may want to add some to that.
No, that was great. So absolutely more sedentary lifestyle can be contributory. And I talk to my patients, all of them, at some point, if not, routinely at their follow-ups about lifestyle changes, including becoming more active. We now know that regular vigorous exercise reduces your risk of breast cancer recurrence. By that, I mean, 4 or 5 times per week, 45 minutes, which sounds like a lot. And it can be, and it is, but you can get there gradually. This is a sort of exercise where you are getting your heart rate up, you're breaking a sweat. So, for those people, there are many people who are sort of taking a leisurely stroll. I talk to them a lot about increasing how vigorous their exercise is. Also, limiting alcohol intake is an important one that we talk to patients about. And I think Dr. Blank mentioned all the other really important points. Aging, absolutely. One important point is that although breast cancer and most cancers are more common in older age, the cancers that we see in older age tend to be less virulent or less aggressive. So those younger patients also need to be paying attention to early detection as well.
Once I started here at TPD, it was the first time that I was in a job where I was in an office all day. Can you talk a little bit about, really, this is for anyone, how easy it is to not realize that you have a more sedentary lifestyle and that you don't move as much as you think you might move on a daily basis?
Sure. I mean, I think we all have phones and Apple Watches and Fitbits and all those sorts of gadgets that kind of help us keep an eye on those things. But I think part of it is just, kind of looking back over the course of the day and sort of, saying, what did I do? What have I done today that didn't involve, sitting down, whether it's, sitting at a computer, sitting at your job. And so sometimes just trying to incorporate something into your regular routine, whether that's, taking a walk or a walk run in the morning doing something at lunch, doing something at the evening. I think most studies show that people that exercise earlier in the day are more likely to stick with it and do it on a regular basis, and that makes sense. But part of it is whether you're a gadget person that can look at those things and that will help you, versus someone who just kind of journals or kind of, at the end of the day looks back and kind of evaluates what you did over the course of the day.
Fantastic. Now let's talk a little bit about the impact of tobacco use with those who've been diagnosed, tobacco cessation. Can anyone talk a little bit about or elaborate on that for me?
I can take that if you want. So smoking cessation is very important in plastic surgery, but it's actually really important for, number one, preventing cancer. So here we are talking about formation of breast cancer, but we know nicotine in particular creates many known cancers in the body. So curing breast cancer and then continuing nicotine use is difficult to make sense of course, because it can cause cancer. So that's number one. Number two, nicotine has very negative effects on wound healing. So if any type of surgery is going to be necessary, anything that requires the skin to heal, we see much higher rates of infection. We see actual skin necrosis, or what people call gangrene, from people who use nicotine. So we like people who find out that they've been diagnosed with breast cancer to try to stop their nicotine immediately and not use any nicotine replacement products, because it's only putting more nicotine into the system.
Thanks so much, Dr. Paredes. And you took us right into the next question of what it looks like when you find out that you have breast cancer. If someone in the community finds themselves diagnosed with breast cancer, what comes next? Dr. Silberman, this question is for you as far as what some of the resources that TMH has that's available for the community.
Sure, absolutely. So I think, as we mentioned already, we do have a breast specialty conference and clinic that goes along with that, and it's multidisciplinary. So many of us are there, all the different specialties involved in taking care of breast cancer patients. That's a great resource. Amy Anderson, our wonderful breast cancer navigator, is also there. Typically what happens when a patient's referred is they'll come in as a referral from a general surgeon, is a very common scenario. The advantage that we have during this breast conference is that we can expedite their workup and get them onto treatment faster. They can be seen by multiple specialists within one day.
And then Amy, talk about the role of the navigator.
So once a patient is diagnosed with breast cancer, it's a very overwhelming experience, and they often have fears and anxiety. So that's when I come in and try to offer support. I offer education, resources, and then coordination of care so that some of that pressure is taken off of them. And so they have that one direct contact that they can come to, and I can help with any barriers they have to care. And all that coming together helps with that fear and anxiety of a new diagnosis for them. The breast clinic is amazing because that allows them to come one day and have everything taken care of. They can meet with the surgeon, they can meet with a medical oncologist, they can meet with a radiation oncologist needed. We have a partnership with the plastic surgeon, so they'll see the patient often that same afternoon. So it's just an amazing system together that helps take care and expedite like timely, safe, and effective care for our patients.
And Dr. Blank, would you like to add anything about the breast clinic as the director?
No, I mean, I think that Amy and Dr. Silberman have both kind of summed it up really well. Part of our goal was to, obviously no one expects or wants to find themselves in that situation. Dr. Swain is kind of usually on the front line of that, because oftentimes she's been the one who's identified an abnormality by imaging and maybe done the biopsy. And then they have been extraordinarily helpful in kind of helping patients link up to the resources that are available at our new breast clinic. So the feedback, I think, has been very good. It's a long day for the patient, but I think they walk away with a lot of information and with a framework and a plan, and that sense of control that kind of helps to allay some of the anxiety that goes along with this new diagnosis.
Thanks so much. And Dr. Swain, this next one is for you. What does the process of being screened for breast cancer look like? We're going back just a little bit. Say a patient finds a lump that they're concerned about. What comes next?
Well, actually, a screening mammogram is when you don't have any signs or symptoms of breast cancer. And that's what we recommend that every woman beginning at age 40 have every year. So if you feel a lump or if you have any other signs or symptoms of breast cancer, like a newly inverted nipple or a bloody or clear nipple discharge, then you would have what's called a diagnostic mammogram. And so on the diagnostic mammogram, we actually would tend to do more images, like kind of focusing on that area of the abnormality. Probably also would get an ultrasound as well. And then if we find something that we think needs to be biopsied, then we would recommend either we can do multiple different needle biopsies, we can do them using mammographic guidance, we can use ultrasound guidance, and sometimes we even use MRI to guide us to do a breast biopsy. And then once we make the diagnosis of the breast cancer, then I tend to refer the patient to the TMH breast clinic because in my experience, that is the fastest, most efficient, and most comprehensive way to get them the care that they need.
And Dr. Blank, a lot of women hear the words breast cancer and instantly think of mastectomies. Do all women diagnosed with breast cancer need to undergo this?
Definitely not. And in fact, probably the vast majority of women, particularly with early stage cancers, are great candidates for what we call breast conserving therapy, which is kind of another word for lumpectomy, where we're removing the cancer and we're checking lymph nodes, but the patient is retaining the normal conformation of their breast. That's going to typically be accompanied by radiation therapy, but it's a much more cosmetically normal, if you will, outcome. There are patients that, for whatever reason, whether it's the type of tumor they have, the size of their tumor, their underlying genetic risk, or other factors, they may desire a mastectomy. And that mastectomy can be accompanied, as Dr. Paredes pointed out, by reconstruction. But I would say the vast majority of patients have multiple options for their surgical intervention.
And Dr. Blank, this is for you or anyone else that'd like to answer it. Will you talk a little bit about preventative mastectomies?
Sure. The folks that Katie had referred to and that Dr. Silberman talked about a little bit, there are a small percentage of folks who because of their genetic makeup and an inherited risk for breast cancer, may choose to undergo a preventative or prophylactic bilateral mastectomy. The idea being that their cancer risk is so high that it really warrants a preventative operation. That is, again, the minority of folks that we see, but it can be very effective. Those folks usually have a very characteristic family history where mothers, sisters, grandmothers, multiple folks in their family have had breast cancer at quite an early age. And preventative surgery can be very effective at reducing their risk. I'll let Dr. Silberman and or Katie kind of add to that.
Sure. So surgery, risk-reducing mastectomy or prophylactic mastectomy is absolutely available to any woman who has an inherited breast cancer risk or hereditary cancer syndrome. But I'll also point out that many women, even who have BRCA or similar types of mutations, aren't interested in that surgery because it's a major procedure to have. And so there are options for increased screening being followed closely with mammograms and MRIs by someone like Dr. Swain to be monitored more closely. So if anything does happen, we can hopefully catch it very quickly.
There are also some pharmacologic or medications that can be taken that would reduce the risk if they opted not to have surgery. So that would be the role of the medical oncologist, is when they came in to do a risk stratification. And if they met that threshold criteria, they were at great enough risk, then we would offer them an anti-estrogen medication.
Now, Dr. Paredes, we're coming to you next. Can you talk a little bit about reconstructive surgery? Are all patients who undergo mastectomies candidates for reconstruction?
So my role as a reconstructive surgeon is to take surgical patients who have a missing part of their breast, whether it's some of it or all of their breast is more common, that's a full mastectomy. My job is to help figure out how we're going to reconstruct that. There are multiple different options ranging from implant-based methods to your own body tissue. We call it autologous reconstruction. And I work with the general surgeon to come up with a game plan of how we're going to do that. Sometimes that is done immediately, meaning I would go in with Dr. Blank and we'll start the process on the same day the mastectomy is done. It does take stages, and that's a common misconception that a woman will necessarily wake up with a 100% completed breast reconstruction. It's often done over 2 or 3 stages of surgery over about 8 to 12 months. That's called immediate reconstruction. A delayed reconstruction comes in when, for whatever reason, we can't do the reconstruction at the same time. There may be some cancer reasons, there may be some health-related reasons, and we just want to push it down the road to let all of the cancer care occur first, and then I'll come in towards the end. We call that delayed reconstruction. And either option is possible for most patients. But the question, are all patients candidates for reconstruction? Unfortunately, not necessarily. And that's where a visit with a plastic surgeon is necessary so we can go over a patient's past health and sort of current issues. Common things that are difficult to work with in terms of reconstruction would be an active nicotine user or someone who's actively smoking. And that's why I recommend quitting the moment you get diagnosed. Someone who has poorly controlled diabetes or a very high, what's called body mass index. There's other medical reasons why it would be unsafe to prolong the surgery, or perhaps the cancer is too advanced to prolong surgery. But again, those are the things that we would discuss in a consult with a plastic surgeon.
And Dr. Paredes, we have a follow-up question from a viewer. Can you talk about whether breast cancer or breast reconstruction is an option for scar tissue from a lumpectomy?
Yes, so reconstruction can be done both for mastectomies, when we remove the entire breast, or for lumpectomy, when you remove just a portion. Sometimes when you remove a portion, depending on the size of your breast, in particular the location of the lumpectomy. So if we take a golf ball out of your breast, where it got taken out of can matter. So which quadrant of the breast, or was it under the nipple? That can affect the cosmetic outcome of the breast, especially when it gets radiated. So yes, we do have techniques for, in a sense, fixing or repairing partial defects of the breast. They range from fat grafting, where we actually liposuction or aspirate fat and then re-inject it into your own body. So it is your own tissue. It's like little seeds that we're putting in. Sometimes we do manipulation of the tissue on the inside to fix it. So each person is reconstructed differently. So to the viewer who's asking that question, it really is so specific. We fix things based upon the need. And so we would just have to see the patient and then kind of come up with a game plan. But the answer is yes, very much we can fix it.
All right, it looks like we have another follow-up question coming in for anyone. If a woman doesn't want a reconstruction or isn't a candidate, what other options does she have to make her breasts appear full?
Well, I guess I'll take that one as well. So number one, not everybody wants to have reconstruction. It's important that viewers understand that reconstruction is an elective procedure. Taking out of the cancer, taking your chemotherapy, getting radiation that's recommended, those are all essential parts of curing the cancer and making sure it doesn't come back or grow further or spread. Reconstruction is an attempt to remake the mound. Some patients don't want to go through it. I find some patients are overwhelmed by the idea of having additional surgery and simply don't want to have it, want to come back later, let's say 5 years later, and you can do that. Some patients don't want to have any reconstruction at all. The most common option chosen by patients who don't want reconstruction is to get a special bra with built-in prostheses. And so what that means is in the padding or the fabric of the bra, there's just going to be a gel-made form that will look like a breast, and underneath a blouse or clothing, you really wouldn't notice a difference. That's the most common, and insurance typically does pay for that as well.
They do.
Oh, I thought you were adding something else. All right. So what options does TMH have for regular and proactive breast health care outside of being diagnosed? This question is for anyone.
So we definitely have outpatient mammography for screening, as well as for diagnostics. Clearly, we have navigational services as well as genetics, and then our comprehensive breast center. Currently, our comprehensive clinic is more designed for patients with new diagnosis of breast cancer, but I think the expectation is that over the coming months to year, we would like to expand that to high-risk surveillance. So patients that may have, for whatever reason, a high risk and need special screening, that we'd like to include that. So from imaging to genetics to just high-risk screening, as well as survivorship follow-up, we kind of offer all of those options.
We have another question. I'm sorry, go ahead. Go ahead.
I was
I
going
would
to say
say-
also have physicians that they can meet with all under one roof at the cancer center.
Amy, I think the first part of that got cut off. Amy, you start over, and then Katie, as soon as she finishes, we'll hear from you.
Sorry, Katie. I was just going to add, we also have registered dietitians that they can meet with too, to help with different things like weight loss and, trying to lead a healthier lifestyle. We have those available.
And then as far as genetics, a way to be proactive is just to know your family history, ask your relatives, especially the generations above you. If you know they have cancer, what kind was it? What ages were they diagnosed? And if you seem to, have a family history where people were having cancers younger than they usually happen, breast cancers before menopause is really what we call early onset. Or if you have multiple generations with the same or related types of cancers, that's worth mentioning to your physician, your healthcare provider, and asking if a genetics consult would be helpful for you.
We have another question coming in from the audience. How can a patient get referred to the breast clinic?
So right now, again, we're mostly focusing on folks with a new diagnosis of breast cancer. So if you, and this includes some of the pre-invasive cancers like DCIS or ductal carcinoma in situ. If you're someone in that situation, you can talk to the person who did your biopsy, whether that's the radiologist when they give you your results, or your primary doctor, and they can refer you. If you don't have a new diagnosis, but you need survivorship services, surveillance, those sorts of things, if you reach out to Amy, she'll be able to kind of direct you toward us, not in our comprehensive new diagnosis clinic, but in our follow-up clinic.
What are some of the biggest misconceptions that you see people coming in, whether they're newly being diagnosed or just being diagnosed, or they've known for a while that they have breast cancer? What are some of the misconceptions? This question is really for anyone that you're seeing from people that are coming in.
I guess from my perspective, we all spend a lot of time talking about how multidisciplinary the treatment of breast cancer is. And I think that's important because as you sit down with a patient and you go over their treatment plan, we'll outline, for example, a typical scenario would be you start with surgery, and then if you need chemotherapy, that comes next. And then for those that need radiation therapy, that follows that. And then for those with hormone receptor positive breast cancers, that would be, that final stage of active treatment, and then you go into surveillance. One of the issues that comes up frequently when I'm interacting with patients is they ask whether or not one of those treatments can substitute for another. So if I do surgery, can I omit, radiation? Or if I do radiation, can I omit chemotherapy? And I would just caution people about that because really it is a multidisciplinary specialty for a reason, and that is because all of those treatments are effective when they are used, sequentially in that specific sequence without omission of any particular treatment. Now, there are a few exceptions to that, such as in elderly patients, but I would just, caution people not to think that if I have bilateral mastectomies, then I can skip chemotherapy if that's indicated.
Another question coming in from the audience: is it possible to get breast cancer twice or in both breasts?
It is. We will occasionally see a patient who's diagnosed and has either more than one area of cancer in the same breast or a bilateral diagnosis, so a breast cancer in each breast. The other thing we see is someone may have a breast cancer that's treated effectively, and then 5-10 years down the road, they develop a cancer either on the other side or elsewhere in the same breast if they have had a lumpectomy in the past. So that can happen. Certainly one of the biggest risk factors for having a breast cancer is having had a breast cancer in the past. So we do see that happening. Now, does that mean that, everyone needs a bilateral mastectomy? No, certainly not. And we, obviously have ways of treating that. And each individual breast cancer, we kind of reevaluate, and they may be the same sort of breast cancer, or it may be a different type and warrant different treatment. I think what Dr. Silberman said was very important. I think, many years ago, all breast cancer was treated the same. And so one of the biggest advances is realizing how differently all different types of breast cancer behave and tailoring that treatment really individually to the patient. So one of the biggest misconceptions that I see are patients who come in and they've had a friend or a relative who've had a breast cancer, and they sort of expect their recommendations to be exactly like the person they've known. And that's not really the case, because many of the recommendations are very specific depending on what type of cancer that you have.
I also add to the question about the bilateral breast cancers or multifocal breast cancers. Over the past maybe 10 years or so, we really recommend that anybody who is newly diagnosed with a breast cancer have breast MRI. And the reason that we recommend that is because MRI is more sensitive than mammography for detecting breast cancer. We don't screen with it because it's so expensive, but once you've been diagnosed, we recommend that you have an MRI, because basically studies have shown that in 25% of cases, there'll be a breast cancer in the same breast that we don't see mammographically as the initial cancer, and 3% of cases will have bilateral breast cancers that we don't see on the mammogram. So we recommend breast MRI in anyone who's been newly diagnosed with breast cancer.
And I'll also add on to that, that if you do have multiple primary breast cancers, either at the same time or years apart, that is an indication to think about genetics, because we ask the question, why has this individual had 2 breast cancers versus just 1 or none, as most individuals would have?
Another question, this one really is for anyone. Are there any support groups for those of us after mastectomy? This is a viewer question coming in, who are no longer coming to the clinic. So any support groups for anyone who after mastectomy is no longer coming to the clinic for chemo and or radiation?
There is a local support group. It's Joanna Francis Living Well, and they meet monthly. And they have a website where they can look up that and get the information for that website. Currently, the support groups at TMH Cancer Center aren't meeting because of COVID, but Joanna Francis is meeting.
Thank you so much for that information. Another viewer question coming in, what are the differences between the different stages of breast cancer?
I'm happy to take that. So stage 1 and stage 2, first of all, there are 4 stages. There's actually there are 5. If you include non-invasive breast cancer as stage 0. For the invasive breast cancers, there are 4 stages. Stage 1 and 2 are what's considered localized breast cancers. Stage 3 is a more advanced regional breast cancer that involves the lymph nodes and larger tumors within the breast. And stage 4 is metastatic, so it's gone to distant sites outside of the axilla or the lymph nodes under the arm. So that can be in the bone or the brain or the lung. So those are the four stages of invasive breast cancer.
And then what is the difference between chemo and radiation?
So chemotherapy is an intravenous treatment that typically we give after breast cancer surgery to try to prevent it from coming back. And you might hear that called adjuvant therapy. So that's for cure for early stage breast cancer to try to prevent it from recurring. We also give intravenous chemotherapy and oral chemotherapy to more advanced breast cancers, so stage 4 breast cancers. And that's to try to minimize the growth for as long as possible, understanding that it's incurable.
And talk a little bit about the support that a family or a significant other plays in the role of someone being diagnosed with breast cancer. You know, what are the different ways that they can support them, and what do you wish that they knew that they could, the things that they could do to help someone who's been diagnosed?
I think that you directed at me. I couldn't hear you. You were blanking out. But so when you have a patient or a family member that's diagnosed with breast cancer, like it affects, everyone in that household. So being there for them, a lot of times if you come with them and get them different things they like, and I mean, it's a family tradition. I mean, I'm trying to think of the right words. It affects the whole family. So not just the individual. And so being there for each other, we have counseling services that are available at the cancer center. And so if you utilize different services, then, we're there to help them get through it together.
One thing I would add is that a lot of patients don't want to share their diagnosis with their family because they don't want to worry their family, or they don't want to burden them. And we strongly, obviously, discourage that. And really, families want to help. They just don't really know sometimes what to do. Also, children that are a little bit older, they sometimes don't know how to or don't want to tell their kids. And kids are very perceptive, and they will know that something's going on. And if you don't tell them what's really going on, they're going to presume something worse. Or when they do find out or overhear or see your appointment card, they're going to presume that you're going to die from breast cancer because otherwise you would have told them. So these are things that, it's another layer of anxiety that goes along with the diagnosis. But I would say just being there for the patient, offering support, talking about their diagnosis, because it's on their mind all the time. And so I think bringing it up and kind of demystifying it a little bit and kind of realizing that this is front and center for a little while, but your life is still your life. And hopefully for most people, pretty soon you can kind of put it into its little box on the back burner and continue your surveillance, but kind of get back to your regular life. But for a while, it's going to be a priority.
And Dr. Silberman, this next question is for you from a viewer. It says, I know you're also a psychiatrist. Can you talk a bit about the importance of taking care of your mental health after a diagnosis?
Yes, absolutely. So it's very important. As you can imagine, there's a lot of anxiety and depression amongst patients with, especially a new diagnosis, but also with patients who are fighting a chronic battle with stage 4 breast cancer. So it's really important that we, in reviewing what's going on with the patient at the time of their visit, that we go through all of those check boxes. What's going on with their mental health? What is their level of stress? So we have these inventories that we give our patients to try to gauge where they're at mentally, as well as physically, because that's such an important part of their treatment.
As a community, what are some things that you want more people to do? I know we talked about the preventative measures and the different ways that the community can step up, but what would your message to them be as far as how, just like Amy said, it's something that can impact the entire family. And I think that educational component is really key in households. Does anyone want to chime in a little bit more about the community aspect?
So I'll try to at least start. There are, again, there are, in a perfect world, there are more support services. Obviously, in the last couple of years, we haven't had some of the things that we're used to, but there are definitely, support groups. There are educational opportunities. We try to, at that kind of initial visit, and then as we go along, try to provide educational materials and resources for patients and families to try to help them kind of through the process. I don't know if that kind of answers the question, but and there are great resources like, as Amy said, the Joanna Francis Living Well, who offer kind of multiple aspects. So education, support, camaraderie, and fun activities, as well as fundraising and local community awareness. So there's kind of a lot of things going on with some of the groups.
Another question coming in from a viewer. It says, if I've had another type of cancer, is my risk for breast cancer increased?
This is probably a good question for Katie. It may or may not be, is the
So,
answer. So it depends on
really
what those risk
depends.
factors that have led you to where you're at right now. So there are some hereditary cancer syndromes that predispose you to multiple cancers. So it's important that you go through your family history so that can be whittled down, and also the testing aspect of that to look for those genetic mutations. And then there are also some lifestyle factors that can be contributory in more than one cancer type. I'm sorry,
I would agree
Katie,
with
go
Dr.
ahead.
I'd agree with Dr. Silberman that it's hard to answer one way to that particular viewer because it really does depend on what the cancer was. But those would be good questions for your primary provider or your past oncologist about, you know, does my past diagnosis, the age that I was, the type of cancer, the rest of my family history, is that concerning for an underlying syndrome, or does that predispose me to anything else?
And Katie, how often do you find that people have just never asked some of those really important questions as far as their hereditary predispositions and just don't know? And it might have been helpful to have known.
Quite a bit, actually. You know, I would say this generation and generation coming up, we're much more open about talking about cancer diagnoses, sharing it with our family members than generations prior. You know, not too long ago, cancer was not talked about, even to family members, especially female type cancers. They were not shared and not shared with children. So I have a lot of patients who come in and they might know some about their parents and their siblings, but when we try to ask about aunts or uncles or grandparents, which really is still a close relative, those are second degree relatives. Some say, I have no clue, you know, my family didn't talk about that. I don't know what happened. And that can be limiting with the evaluation that we can give and giving them the best information we can. So I would say, you know, trying to change, if your family's like that, trying to change that and talk about what kinds of diagnoses have happened. You don't have to get in the nitty gritty details with everybody, but it's important to know what's in your family so that the health of everyone else in the family might be improved.
We have another question coming in from our audience. It says, my loved one had lymphedema therapy after her breast cancer treatment. Can you talk a little bit about what that is and who needs it?
Sure. So not everyone will share the same risk for lymphedema. And lymphedema is essentially a result of any of the axillary lymph node removal and or radiation that we do under the arm. And so removing those lymph nodes and or radiating that area can result in the lymphatic channels of the arm not having the normal drainage pattern or places to drain to. And that results in arm swelling, arm heaviness, weakness, and those sorts of side effects. Some of the newer treatments for breast cancer, such as sentinel lymph node biopsy and doing less aggressive surgery in the axilla, have certainly reduced our rates of lymphedema, but some folks will need that more aggressive either axillary surgery or axillary radiation, and or may have more advanced cancer that can make you at more high risk for lymphedema. So if you are having mastectomy and we know that you're going to have an aggressive lymph node dissection surgically or radiation, you might be a candidate for having preoperative evaluation and measurements as well as postoperative treatment. And that can include different kinds of massage, keeping a track of measurements to see how much arm swelling you have, creating a sleeve that offers compression to keep that lymphedema from ever forming. We don't do it in our community, but there are centers that do lymph node transplantation to try to help people with chronic lymphedema that are good candidates. So there are a lot of options, and there are great physical therapists that specialize in this that we can refer patients to that might need it.
And sort of staying on that topic, if only a sentinel node is removed during a mastectomy, are you forever subject to the no BP IV needles in the arm on that side to prevent lymphedema?
So typically not. I think the newer data indicates, particularly if you haven't gotten radiation to the axilla and you've only had 1, 2, or 3 lymph nodes removed, your risk of lymphedema is extraordinarily low. It's not zero, but it's still very low. And so we don't really feel like the same restrictions that we used to place on people as far as no blood draws or blood pressures in that affected arm really are necessary. So I would have a discussion with your surgeon about how much dissection was required, how many nodes were removed, and that will kind of speak a little bit to your risk. Again, if you have, if both arms are an option, I would always kind of defer to the other arm, but if it's necessary, most of the studies say that risk is very, very low.
I think based on the questions that have come in from our viewers, there's a wealth of knowledge on this panel, just like we talked about at the very beginning, but there's plenty of information and questions that people still have. So we want to make sure that if anyone has any additional follow-up questions about their personal breast health or would like to ask questions, who can they contact?
So Amy, you want to give our website? That's probably the best foray. Obviously, any of our, we all have our own personal offices. I'm at Tallahassee Memorial Physician Partners. And then Amy is our navigator, and she's usually a good entry point, and then she can kind of direct questions or if someone needs a referral, but also through the website is on our TMH website is a really good place as well.
Yeah, I'm happy to talk to anyone with a breast cancer diagnosis or with just a breast health question. I'm happy to talk to them. They're more than welcome to call me at the TMH Cancer Center.
Fantastic. We're coming to the end of our time here. And in closing, I want each of you to chime in and tell us what is the most important message you want our viewers to walk away with from this today. Dr. Swain, I'll start with you.
Get your annual mammograms.
Dr. Silberman?
Don't be afraid of getting your mammogram. So.
Absolutely. Thank you so much.
I agree. I'm going to repeat that early detection is key. And then I want to just also add breast cancer is many different types of cancer all rolled up in one. There are many different types based on how quickly the cells are growing and dividing, what receptors are present on the cancer and various stages of the cancer. And so, when you talk to your friend, just keep that in mind that your breast cancer might be entirely different. So have an open mind when you come in and you talk to your physicians.
Dr. Paredes, one message you want the viewers to take away from today?
I would say a couple of things. Number one, it is never too late to adopt a healthy lifestyle. So that can start tonight or tomorrow. And number two, for those of you who are diagnosed, I know how scary it is. I have been through this with my own family members. What's really important to know is, at least here in Tallahassee, we have an amazing group of physicians who are really very talented at their specialties, and we all work very closely together. We call each other. This is a place that you can get excellent care, and so at least have some confidence that you'll get really good care right here locally.
Katie?
Know your family history and start asking those questions so that then you can know what your level of risk may be.
Dr. Blank?
I would echo all of those. The biggest thing I would say is we have great treatments for breast cancer of all types. And that is evolving, month to month. I mean, the progress is amazing. So if you are concerned or you have a new diagnosis, don't feel like that this is in any way something that is not, does not have a great treatment.
Thanks. Amy?
So I'm going to echo on what everyone said. Number one, get your mammogram. It's very important. And then know that at TMH Cancer Center, our goal is to support you. We have a very passionate staff that all work collaboratively to stand with you through your whole process. So we're here for you and you are not alone.
Thanks so much. I want to thank each and every one of you for your time today. Thank you all who tuned in for this important and very informative discussion. If you're interested in learning more about breast cancer and the incredible care offered at TMH and more ways to raise awareness through the month of October, visit tmh.org/GoPink. Thank you everyone for joining us and have a great evening.
Thank you.
Thanks for having us.